Hi, very good morning. I'm Dr. Janak Patel. I'm a general physician. Today we'll be discussing on very useful topic which every day in and out you will be seeing a patient with pain. So by taking a good history you will be able to make out the diagnosis of the pain symptom. It is due to what, and accordingly you will treat. But in general the pain management is very important because depending upon the etiology the treatment will change. So analgesic is not the only answer for pain management. So we'll be dealing with that particular aspect. So there are three compounds which we commonly use during pain management. One is analgesic, antipyretic, because very frequently with pain there is associated symptoms like headache, body ache, muscle cramps, etc., and anti-inflammatory. So analgesics are the drugs which will reduce your pain. Antipyretic which reduces your temperature, and anti-inflammatory which reduces your inflammation. But there are other material also which are used along with the pain symptom, that is antispasmodic, where the person has got spasm of smooth muscles, say in ureter, uterus, say in case of a small intestine, stomach, large bowel, etc. Or you get skeletal muscle sprain and they are in spasm. You use what we call as a muscle relaxant to reduce your spasm and to reduce your pain. So these are all the material which will be utilized in a pain management. So we'll be dealing under the heading pain, what is pain, what are the different types of pain, etc., classifications. Then we'll be going to pain management. We'll be using all the different compounds which are commonly utilized as analgesics, and we'll be also talking little bit regarding a non-pharmacological treatment, and then we'll have a case discussion. Pain intensity is taken as a vital signs, is included in one of the vital signs. Normally we check only 4 vital signs, that is pulse, blood pressure, temperature, and respiration. But pain intensity is taken as a 5th sign, and even level of consciousness is also included in a vital sign. They also include urine input output chart, cyanosis, and skin conditions, etc. They are also included. So pain service is a part of hospital management, and pain relief is a basic human right. On a humanitarian reasons, inadequate pain relief increases the morbidity and mortality, because it will end up with acute pain, will end up with what we call as a chronic pain, and then person will need treatment for very long period, and there are a lot of side effects of person once he goes into chronic pain. So for assessment of acute pain there are 2 things which are very commonly utilized: visual analog score and facial grimaces. So you can utilize any one of these. This is the most common which is being utilized, and you put the score from 0 to 10. So accordingly you can put them into the severity, mild, moderate, and severe, etc. Basically pain is a protective function for withdrawal reflex. It is also for a defensive function. So during pain person immobilizes, and when he gets a prick he immediately has a withdrawal reflex. And good number of time where is the pain, sight will give you the answer regarding diagnostic. So it gives you an idea regarding which organ is involved. So basically pain is a protective mechanism. Say a person complaining of a headache, Very frequently it is because of the structure related to head. Sore throat related to the upper respiratory tract. So depending upon that, heart attack, aching chest pain, arm aches, hand pains, finger pains, heartburns, joints, calf, muscles, ankle, etc. These are many areas where you get a pain. Even a person who gets elevated body temperature will have a non-specific general body ache. Very common. And because of pain, person gets increase in heart rate good number of time. If the pain is very severe, he can get diaphoresis. As a stress phenomena, you get increase in the blood sugar level. There's a dilation of pupil. There's a decreased GI motility, increased muscle tension. So tone in the muscle is increased, and even your respiratory rate is increased. So these are some of the effects because of an acute severe pain. If acute pain is not controlled, it is poorly controlled, it will lead to peripheral sensitization. And because of peripheral sensitization, person will develop hyperalgesia, meaning increased wound sensitivity, prolonged discomfort. He'll constantly complain of pain in the affected area, particularly area in where the injury is there. Secondary to peripheral sensitization, now there is a central sensitization, which will give rise to secondary hyperalgesia. And because of that, there will be increased incident of pain and prolonged disability. And this central sensitization now will give rise to neuronal and glial remodeling, and that will end up with a long-term plasticity, that is increased muscle spasm, and that will produce chronic pain. And this chronic pain will continue for a very long period, even in absence of the wound which has given rise to, which was the origin of pain itself. So do keep it in mind. Poorly controlled acute pain can end up with what we call as a chronic pain. Now, this is very sure that this person will not require any treatment for pain. While this person who is shouting because of a just small injury, while another person with a fever may not require an analgesic, but antipyretic can do a work. But this particular person with a severe acute headache, acute arthritis, will require a treatment with analgesics. What a good physician will do, he will treat the disease. While what a great physician will do, he'll treat the whole patient. Means he'll treat the disease as well as he'll control the pain. While what a doctor will treat only pain will be considered as a bad doctor. Just relieving pain is not the answer. You have to treat a patient as a whole. You have to identify the cause of pain and treat that simultaneously. So there are a lot of different types of presentation like toothache, headache, severe chest pain because of acute MI, colicky pain, renal colic, cancer pain, post-operative pain, etc. So you can come to the diagnosis, the type of care, or what we call as a character of the pain, type of pain, etiology of pain, by taking a good history, that is onset, temporal pattern, site, radiation, character of the pain, severity of the pain, exaggerating factor, relieving factor, response to analgesics, response to other intervention, associated physical symptoms and associated with psychological symptoms and signs. So all this you can take in a history and then decide what is the type of a pain, whether it is somatic, whether it is visceral, whether it is a referred pain, whether it is a projected pain, radiating pain, or there is a hyperalgesia. So you will decide regarding that. Also it can be classified depending upon these are the different character of the pain: burning, stabbing, electric shock like, tenderness, aching pain, stiffness, or you can have a pain because of the stomach or duodenal ulcer, or burning character pain, or you can have a small and large bowel pain that will be in the form of a colic. In ureteric colic, ureteric stone, you will have a what is being described as a renal colic. Acute MI will have a typical presentation like heaviness or suffocating sensation, etc. Now this is a presentation showing you each person will describe that pain in a different pattern. So depending upon your good history, you will be able to put them into two big groups. What we call is a tissue damage, or we call nociceptive pain, which is because of damage or inflammation, or because of irritation of peripheral nerve, because of damage and inflammation. We call nociceptive pain. So you treat the tissue damage, you treat the inflammation, pain will be relieved. While in a person with a nerve damage, we call neuropathic pain, which can be because of neuropathy or can be because of central neuropathic pain or peripheral neuropathic pain. In this, just giving an analgesic will not relieve the pain. You will require adjuvant therapy. There is another condition where you can get a pain because of chronic conditions like cancer, which will give destruction of the tissue as well as the destruction of the peripheral nerves, and that will give rise to a chronic cancer pain. So we call that as a chronic cancer pain. Or also there is another condition which may not be malignant but becomes chronic, so then you call it a chronic non-cancer pain. So you divide them into acute pain, which is very frequently because of the damage, inflammation or vascular etiology, and chronic, which is because of the chronic disorders, maybe a chronic inflammations or chronic disease like malignancy, etc. And when it is diagnosed as a cancer, malignancy, then you treat as a cancer pain. And you can have a conversion of an acute pain into a chronic pain, and then person goes into what is called as a chronic pain syndrome. So usually we divide into these 5 groups: acute pain, chronic pain, cancerous pain, chronic non-cancerous pain, and chronic pain syndromes. These are the 5 common classification which are being utilized. So you can divide into acute, chronic, cancer pain, chronic non-cancer pain, and chronic pain syndromes. And depending upon the severity, mild, moderate, and severe. These are few of the classification. Another way of classifying which organ is involved. Suppose if skin, muscles, they are involved, we usually call that as somatic pain. Where superficial skin, if it is involved, we call cutaneous or superficial pain, where the management will become little different. And if it is involvement of the subcutaneous tissue, particularly tendon, muscle, artery, etc., then we call it a deep pain, or we call deep somatic pain. Or you can have what we call as a visceral. Usually the viscera which are being involved depends upon the structure. Say if a small intestine, gallbladder, ureter, uterus, if they are involved, they usually will produce what we call as a colicky pain. And that is due to spasm of smooth muscle which are present in those structures. While a solid structure like liver, spleen, myocardium, etc., they will give rise to a different character of the pain. And in those, you require the treatment simultaneously of the basic etiology. So you will require a treatment in that separately. Or if it is a pain because of a skeletal muscle, then you will get muscle sprain. Now there is another group where there is no basic damage to any particular structure, but person is complaining of pain, which we call as a functional or psychogenic. And in that, you don't require any specific treatment. You require a psychological treatment where you don't require analgesics. So basically the pain, one way of division of the pain can be, you can divide into nociceptive pain and neuropathic pain. So these two groups, nociceptive and neuropathic. Classical example of nociceptive means damage to somatic structures or visceral structures. So mainly somatic structure. So that will be what we call is a nociceptive pain, like arthritis, low backache, spot injury, post-operative pain, etc. This will be damage to skin, tendon, muscles, etc. Those particular structure. While neuropathic pain is mainly because of the nerve, like painful peripheral neuropathy, diabetic peripheral neuropathy, post-herpetic neuropathy, compression of the nerve, say like sciatica, neuropathic low backache, trigeminal neuralgia, following a stroke, central post-stroke pain, particularly in thalamic damage, complex regional pain syndromes, HIV, polyneuropathy, etc. These are all because of involvement of the peripheral nerve. So those we call as a neuropathic pain. So these are the two big groups, involvement of the peripheral nerves or central nervous system, and this is involvement of the peripheral tissue like skin, muscle, joints, etc. But there can be a combination of these two. Yeah. Say a person has got a pain because of osteoarthritis of a spine, and simultaneously there is a compression of a nerve. So you can call that as a low backache, fibromyalgia, we call cervical radiculopathy, cancer pain, etc. where you will have an involvement of the peripheral nerve as well as involvement of the structures. So that way you can divide into three big groups: nociceptive, neuropathic, and where there is a mixture of nociceptive plus neuropathic pain. So this is a very important, because a clinical history will give you a good answer that it is a nociceptive pain, it is a pure neuropathic pain, or it is a mixture of the two. And depending upon that, your treatment will change little bit. So very important, analgesics are the drugs which relieves the pain without causing loss of consciousness. Say you give a local anesthesia, that is not analgesic. Person loses a consciousness, he is not aware of the pain. That is not analgesic. So do remember that. So drugs that relieves the pain are called analgesics. So analgesic will reduce the pain, but it does not treat the disease. So it cannot cure the disease. So you have to have a good history, identify the etiology by investigating, confirm the full diagnosis, and then treat accordingly. So you give analgesic plus treatment of the basic etiology. When a person has got fever, you use antipyretic. So antipyretic which reduces the body temperature and brings back to normal. So in that particular group, it will reduce the temperature. It might act as a mild analgesic, because by reducing the body temperature, simultaneously person gets relief of little complaints like body ache, myalgia, etc. But antipyretics, most common antipyretic utilized is paracetamol, which will not relieve any inflammation. So if a person has got an acute inflammation, it is not going to reduce inflammation, so person will not be relieved of pain for long period. Only it will relieve the temperature, may act as a mild analgesic, but will not reduce your inflammation. And if inflammation is not relieved, the person will not get relief from inflammatory etiology producing a pain, like acute appendicitis, cholecystitis, gastroenteritis, abscess, cellulitis, etc. This is what we call as inflammation. Inflammation will show you swelling, redness, warm, tender, and there will be disturbances or loss of function. When all these five things are present, we call those are the signs of inflammation. You can see this is inflamed. These joints are swollen, and if you examine, they will be warm, there will be little warmness, there will be tenderness. When you look properly, there will be little redness will be there, and there will be loss of function. So anti-inflammatory will act at that level. It will reduce inflammation, it will reduce all these five things, and by reduction in this, it will reduce pain also. So anti-inflammatory will reduce pain by reducing inflammation, and some of the anti-inflammatory also acts at the central level, at the level of thalamus, and it also reduces your fever, body temperature. So some of the anti-inflammatory also acts as antipyretic also. So may reduce inflammation, may act as antipyretic, and because it reduces inflammation, it will also act as a mild analgesic. It may not be a powerful analgesic, It may not reduce your pain completely, but will definitely reduce some amount of pain. So they are mild analgesics. So what we want? A person who is suffering from pain, we want him to smile. So for that we need a pain management. So there are some drugs, say like steroid. Steroid is a powerful anti-inflammatory, but at the cost of reducing inflammation, it also reduces your what we call as the immune response, and by that it will exaggerate infection. So it cannot be used as inflammatory process. But when it is non-infectious inflammation, say like osteoarthritis, rheumatoid arthritis, gout, etc. In those conditions, you can use as an anti-inflammatory in acute episodes, which will reduce your inflammation, and by reducing the inflammation, simultaneously it will also reduce your pain, but may not be used for basic etiology. So remember that steroid can be utilized as an anti-inflammatory in very few conditions, and in which it will reduce your inflammation, plus it will also reduce your pain secondary due to inflammation, but it is not an analgesic drug. While non-steroidal anti-inflammatory drugs are the best anti-inflammatory drugs, but they do not have effect like steroid. So they can be utilized in non-infective as well as infective etiology which is producing inflammation. All analgesics, that is all NSAID, are mild analgesic, a good anti-inflammatory. Some may act as an antipyretic, but some may not have any effect on fever, may not reduce fever appropriately. Opioids. This is a fourth group. Steroid, non-steroidal anti-inflammatory drugs. We have got antipyretics, and this will be the fourth group we call as opioids. Opioids are the most powerful analgesic. They are much more powerful than NSAID, and they are very powerful as compared to even steroid, because steroid will be acting via anti-inflammatory effect and may be a mild analgesic, not a powerful analgesic. While this will reduce your pain irrespective of any etiology, whether it is inflammatory, non-inflammatory, it is infective, non-infective, but opioids is non-inflammatory, non-antipyretic. So it will not reduce any inflammation, it will not reduce any fever. Hence, in a person with inflammatory etiology, infective or a non-infective etiology, where pain may be relieved by opioids, but basic etiology or basic pathophysiology will not be affected, and thus the pain will continue. So opioid is not the drug of choice in a person with an infective etiology and non-infective etiology producing inflammation, as well as it will not reduce your fever. So if a person has got fever with severe headache, opioid should not be given. So that will be the answer. Opioids are basically a opium compounds, maybe a natural or maybe a synthetic preparations or maybe a semi-synthetic preparations. Non-opioid analgesics are analgesic without opium, that is NSAID and steroids. Non-steroidal anti-inflammatory drugs and steroids. So this becomes non-opioid because they do not contain opium compounds. And in NSAID, we have got aspirin, we have got another non-steroidal anti-inflammatory drugs, and we have got a separate compound we call as a acetaminophen or paracetamol, which is not included in NSAID. We have got another group of compounds we call as a muscle relaxant. This will reduce the skeletal muscle spasm, and by reducing the muscle spasm, it will reduce your pain, because pain is produced because of the muscle pain or because of skeletal muscle involvement and that produces the pain, and once you reduce your muscle spasm, the pain will be reduced. While antispasmodic, they reduces spasm of smooth muscle present in certain structures like small intestine, large intestine, stomach, esophagus, gallbladder, ureter, etc. In all these structures, there are smooth muscles. And when this smooth muscle undergoes spasm, it will produce pain. So by reducing the spasm, it will reduce your pain and they will act as a mild analgesic. But they will not be antipyretic, not anti-inflammatory. So if a person has got cholecystitis, it will reduce pain, whatever pain is produced because of spasm, but it will not reduce the pain because of infection of gallbladder like cholecystitis. Neither it will reduce your fever, which is because of inflammatory pathophysiology, that is infective pathophysiology involving gallbladder. Same thing will happen in appendicitis. It will not reduce your pain because of acute appendicitis. So do remember this. So if you understand this, you will be able to decide what you want to utilize in which etiology. Best, if there is no brain, you don't perceive the pain because pain will be transmitted from the stimulus via the peripheral nerve to spinal cord and from spinal cord to thalamus and from thalamus to the cortex. So if the brain is not there, 100% you will not have pain. So this becomes the best treatment for pain management. Will you advise? 100% no. So pain management becomes a challenge and it is very, very difficult unless you identify the cause, because there are a lot of causes for pain. So if you can't identify the cause of pain, you will not be able to manage the pain completely. So for the pain management, first is diagnosis of pain, put them into a different groups like neuropathic pain, nociceptive pain, mixed pain, depending upon the severity, mild, moderate, severe, depending upon the duration, acute and chronic, etc. You try to put them into those groups. And after putting them into the groups, now the problem comes, you got thousands of preparations available, permutation combinations available for pain. We call as analgesics and opioids, even steroids. So choice of drugs becomes very difficult. What you want to use in acute pain, in chronic pains. So there are a lot of drugs which are available and person always gets confused. And you have to decide what you want to use. So again there is a question, what you want to use. Say a doctor prescribes a drug and a chemist has got a big list of all these drugs. It becomes very difficult to search out where that material is present. So again, a good doctor will write down a medication which is very, very important, very useful. So as a doctor, we have to use a logical approach to the pain control. You've got a lot of methods to go for a pain control. You can use analgesic, ibuprofen, paracetamol, and you can use this also to relieve the pain. Yes, it can relieve the pain permanently. So again, there is a question, what to use. So pharmacist writes down, you will not feel pain, you will not feel pain. That is not the answer. Treatment to be pain-free is not the answer. You have to have a proper prescription. So for a pain management, we have got one, medications, and we have got lot of other things which can be complementary. So like educations, physical therapy, what we call physiotherapy, social intervention, psychological psychotherapy, complementary therapy, etc. So we divide into drugs and non-pharmacological therapy. So non-pharmacological therapy is also very useful, but it is more useful in a chronic pain rather than acute pain. In acute pain, very few non-pharmacological therapy is useful. For an acute pain management, we have got lot of medications like opioids, non-steroidal anti-inflammatory drugs, steroids, etc. And that can be available in the form of oral or maybe parenteral preparation like intramuscular preparation or IV preparations. They may be available in the form of suppositories, transdermal patch, transmucosal applications like gel, may be available in the form of injections which can be given intrathecal, or can be given intra-articular, or you can use analgesics or anesthetic as an epidural anesthesia, or can be prescribed in a person and can be given in the form of a drip to a person, and patient control analgesics. So patient will control himself the drip, how much to give, when to stop, etc. Or it can be given in the form of a acufusor. These are the different methods by which you can give analgesic drugs. In a person who has got a chronic pain, particularly a neuropathic pain or a cancer pain, epidural anesthesia, intrathecal anesthesia, nerve blocks, and in a case of a chronic articular pain, you can go for an intra-articular. As far as a non-pharmacological therapy, TANs is very commonly being utilized. There is another method called PANS, that is percutaneous. This is transcutaneous. Acupuncture, acupressures, heat application, cryoanalgesia, etc. These are a lot of methods which can be utilized. So there is lot of techniques like acupressure, acupuncture, TANs, PANS, choreopractice, cupping, ice, heat, massage, exercise, cognitive behavior therapy, relaxation therapy, biofeedback, hypnosis, neurostimulation, anesthesia, nerve block, surgical intervention, heat and cold, psychological treatment, biofeedback, behavior therapy, massage, art therapy. Even nowadays there is music therapy, aroma therapies are also being utilized. These are all called non-pharmacological treatment, but these are mainly in person with chronic pain, not with acute pain. Now we come across what we call as the four big groups: antipyretic, analgesic, anti-inflammatory. These are the three main groups of drugs. And fourth groups is we call antispasmodic and muscle relaxants. And this we call adjuvant therapy, or we call as a non-pharmacological therapy, which is not related to any of the pathophysiology, and that you utilize, and that is very commonly utilized in a neuropathic pain and very commonly utilized in a chronic pain, particularly cancerous and non-cancerous chronic pain. As far as antipyretic is concerned, and only utilized for fever. Anti-inflammatory is utilized if a person has got infective or a non-infective inflammations. And antispasmodic is utilized when the person is having a spasm of smooth muscle. And muscle relaxant are utilized when the person is having skeletal muscle spasm. So this is the main prescription of a drugs in a specific conditions. Analgesic you can divide into opioids and non-opioids according to the inflammatory action: steroids and non-steroids, non-steroidal and anti-inflammatory drugs, DMRD, and there is also one group we call as a 5-LOXI inhibitors, LOX inhibitors. Or you can divide into morphine likes or opioids or narcotic analgesic, that is sedative analgesics, analgesics which are having anti-inflammatory property, that is non-steroidal anti-inflammatory drugs, and steroids. So this non-opioids is steroids plus non-steroidal anti-inflammatory drugs. These are the two big groups. So you divide into opioids and non-opioids, and then that non-opioids you can divide into steroids and non-steroidal anti-inflammatory drugs. So opioids become non-steroidal, but they are not anti-inflammatory. So you cannot include this opioid into the second part of this anti-inflammatory drugs because it is not anti-inflammatory drugs. So antipyretic, analgesics, anti-inflammatory, antispasmodic, muscle relaxant, and adjuvant therapy. So you can divide into a strong analgesics, or we call opioid analgesics, and non-opioid analgesics we call as a weak or a mild analgesics, which are basically we divide into three groups: aspirin, paracetamol, and non-steroidal anti-inflammatory drugs. And among opioids, we can divide into opium, semi-synthetic preparations, and synthetic preparations. And we commonly utilize three groups: opium alkaloids, codeine preparations, and semi-synthetic preparations. And you can have another compound. These are also called narcotic, and these are also called non-narcotic. And you can have one compound which is a basically belonging to the opioid. It is a semi-synthetic, it is a synthetic preparations, but having a mild property or major property of what we call as opium groups, but mild narcotics, not a severe narcotic. So that's why that is pushed into a mixed group, having a mild property of this, mild property of this. Basically, these opiums are prepared from these seeds, opium seeds. Now, if you go through the pain management, there are some drugs which are acting at the periphery, like non-steroidal anti-inflammatory drug, local analgesics, and steroids. They act at the peripheral receptors level. And there will be the drug which will be acting on the peripheral nerves or at the level of what we call as the spinal cord level. And those are gabapentin, pregabalin, carbamazepine, opioid alkaloids, local anesthetic, topical analgesics, etc. And the drugs which acts at the central level, which acts at central sensitization, like anticonvulsant drugs, particularly we call as anti-epileptic drugs. There are a good number of anti-epileptic drugs which can be acting at that level, like carbamazepine. Then even we call which will prevent central sensitization, like COX-2 inhibitor, opioids, ketamine, and alpha-2 agonist. Central sensitization can be also affected by antidepressant, tricyclic antidepressants, and opioids. Also, it can increase inhibition by using antidepressant drug, tricyclic antidepressant drugs. Also, you can utilize clonidine, which is having effect at the level of central. And to modify the expression, anxiolytic drugs. So these are the groups which are being divided, and sometimes some of these treatment are very useful when there is a central sensitization. So these drugs will be very useful in a central sensitization when acute pain becomes chronic, particularly chronic cancerous pain, etc. You can divide NSAID into non-selective and selective COX-2 inhibitor. Non-selective are the groups acetic acid, meclofenamic acid, then oxycams, that is piroxicam, meloxicam, etc. Propionic acid like ibuprofen groups, salicylate, that is aspirin, and choline compounds, trисalicylates like salsalate. While selective COX-2 inhibitor are celecoxib, rofecoxib, etc. So you can divide into non-selective COX-2 inhibitor, preferential COX-2 inhibitor. So this can be further divided, this non-selective and selective, and that selective can be further divided. Non-selective and preferential. Non-selectives are ibuprofen, diclofenac, piroxicam, indomethacin. These are commonly utilized. While preferential are nimesulide, meloxicam. While highly selective COX-2 inhibitor, celecoxib, etarocoxib, and rofecoxib. There are some compound will be powerful antipyretics but mild analgesic, and of that comes paracetamol. So by and large, this is a better classification rather than this. So non-selective groups, preferential selective groups, which has got a major action as a selective COX-2 inhibitor plus mild COX-1 inhibition. They are better than this compound. They are better than this compound. And selective COX-2 inhibitor are celecoxib, etarocoxib. Atocoxib is available, celecoxib is not freely available, and analgesic antipyretic is paracetamol. So pharmacological action of non-steroidal anti-inflammatory drugs, analgesic, antipyretic and anti-inflammatory action. All these three actions are there. Antipyretic effect is because of direct action at the level of hypothalamus and also partly because of anti-inflammatory action. While some of the NSAID will only have these antipyretic effects, while all NSAID will be anti-inflammatory, and secondary to anti-inflammatory, it is also analgesic because it is also acting on a peripheral receptor and at the level of peripheral nerves. Some of the NSAID will have respiratory stimulation, some metabolic effect, very few has got immunological effects, some can have uric acid excretion, so can be utilized in gout, very rare, not common. And aspirin has got a powerful effect as an antiplatelet. It prevents the platelet aggregation by which it will prevent the clot formation and can be utilized for prevention of thrombosis. So it is utilized for prevention of thrombus formation in a person with endothelial damage secondary due to atherosclerosis. Those are available as oral preparation, ointment. Some are available in the form of intramuscular injection, IV injections. Aspirin is also available in the form of what we call as a patch, etc. Transdermal preparations, etc. So action wise, these are the three common action: analgesic, antipyretic, anti-inflammatory. Also they have got some effect which are not required because of COX-1 inhibition, that is gastromucosal damage. It can give rise to gastric ulcer, duodenal ulcer and can produce bleeding. Antiplatelet aggregation is useful only in person with atherosclerosis or person with atherosclerosis with thrombus formations. We call as advanced atherosclerosis, in unstable angina, etc., acute coronary syndrome. In all those conditions, cerebrovascular strokes, TIA, in all those conditions you can utilize aspirin, but it is unwanted effect in other conditions. It is also useful for duct closure because when those are given, it will give rise to a closure of the duct, patent ductus arteriosus. And there are only two compounds which are very commonly utilized is indomethacin and aspirin. Indomethacin is much commonly utilized rather than aspirin. So duct closure, indomethacin is of use and no other drug is effective for duct closure. Yes, when they are utilized or when they are given to a female, a pregnant lady, for analgesic purpose, they may induce labor and can also produce menorrhagia, dysmenorrhagia. So should not be utilized, but sometimes that is also used for induction of a labor, but has to be with caution. It is partly nephrotoxic, so do keep it in mind. Unusual dose for longer period can give rise to kidney damage. Particularly aspirin can give rise to anaphylactic reaction. So whenever you use aspirin, be aware of anaphylactic reaction. Cardiovascular, no direct effect, but indirectly when you use a large doses, it increases the cardiac output and then it also produces vasodilatation by which it will produce hypotension. As far as blood is concerned, we have already told you antiplatelet effects. It interferes with platelet aggregation, so it will prolong the bleeding time and it will give rise to bleeding. But it is very useful to prevent the formation of a thrombus. It also increases the utilization of glucose and blood sugar may decrease partially in a person who are diabetic. So you have to be aware of when the some of the NSAID, when they are utilized in a good dose for a prolonged period, it can produce reduction in a glucose level, particularly in a diabetic person. So you should be aware of that. So if you combine together the side effects of analgesic, that is NSAID, nausea, vomiting, most common. If they are not selective COX-2 inhibitors, if they have got a COX-1 inhibition, they will produce peptic ulcer disease and can produce hematemesis. As far as kidney is concerned, they can produce AKI, CKD. Aspirin can have anaphylaxis. They are also mild hepatotoxic, so can produce an acute damage or chronic damage. Particularly, paracetamol can produce an acute damage in children when they are given in a larger doses. Even aspirin can produce a damage to the liver. You should be aware of that. There are other NSAID also can produce acute damage to the liver. Some of the analgesic, particularly aspirin, can produce angioedema. It can also produce bronchospasm. Aspirin can produce bronchospasm. So it can precipitate asthma. So it is contraindicated in bronchial asthmatic. Even previously they used to say that don't give aspirin in person with COPD also. But nowadays that particular contraindication has been removed. Also it should not be given in a person with a hemolytic anemia. It can produce hemolysis. Some of the analgesic, particularly indomethacin, can produce tinnitus, headache, dizziness. So these are some of the major side effects which you can come across in different NSAID together. There are some drugs which interferes with the action of NSAID, say like diuretics. Results will be they will interact, they will decrease the diuresis. Beta blocker will decrease antihypertensive effect of beta blocker. NSAID will decrease the beta blocker action. ACE inhibitor, it will decrease the antihypertensive effect of ACE inhibitor. On anticoagulants, particularly aspirin, will increase GI bleeding. And even other non-steroidal anti-inflammatory drug will increase the chances of GI bleeding if a person is on an anticoagulant. As far as sulfonylurea is concerned, it will increase hypoglycemic risk because some of the NSAID will increase hypoglycemia. Cyclosporine, alcohol can increase GI bleeding. So these are the drug interaction you should keep in mind when you are using NSAID. So there are therapeutic disadvantages, there are therapeutic advantages. If you are interested, you can just go through little bit. So I mentioned some of the drugs. There are some advantages, some disadvantages. Aspirin has got low cost, long history of safety. These are advantages I am putting here. Less GI irritation than aspirin are these salts, diflunisal, flunizal. Then indomethacin has got a long half-life, so has to be given once a day is enough. Among propionic acid, lower toxicity and better than other groups. So they are better NSAID, that is like ibuprofen. Piroxicam has also got a long half-life, so can be given OD. And less GI irritation than aspirin, that is COX-2 inhibitors, so they have additional advantage. So these are the advantage of different groups. What are the advantages? Disadvantages: aspirin will produce bleeding tendency. Also indomethacin will have a high bleeding tendency. This particular group of compound, that is salicylate salts, do not have antipyretic effects. So if there is a fever associated, you will have to use another separate antipyretic drugs. No doubt indomethacin is a powerful analgesic but has got a toxic side effects because it has to be used in a little larger dose and you can get a CNS side effects. While COX-2 inhibitor, potential for increasing myocardial infarction and stroke, celecoxib. So because of that side effect, slowly these are getting outdated. So these are the some advantages and disadvantages. So you have to keep this thing in mind. Putting together COX-1 and COX-2 inhibitors, selective COX-2 inhibitor, and these are COX-1 as well as COX-2 inhibitor like diclofenac sodium, etc. And selective COX-2 inhibitor like celecoxib, nimesulide, that you can put here because that is preferential COX-2 inhibitor. Both has got analgesic, antipyretic and anti-inflammatory action. But COX-2 will have a more anti-inflammatory rather than COX-1 inhibitors. Means common NSAID. Antiplatelet effect is more by aspirin. While gastric mucosal damage is more with non-selective COX-2 inhibitors. CKD, as far as salt and water retention is concerned, is equal in both. As far as effect on uterus is concerned, prolongation of labor, delayed labor will be very common with non-selective COX-2 inhibitors. Ductus arteriosus closure will be by indomethacin and by aspirin. Aspirin will induce asthma. So side effects, while COX-2 inhibitor, no side effects on ductus arteriosus, no effect on what we call as respiratory passage. As far as the cardiotoxicity is concerned, there is a question mark, that is we call celecoxib. They are cardiotoxic or they have got a high chance of stroke and myocardial infarction. So there is always a question mark whether to use or not to use. Now talking about aspirin, they are analgesic, antipyretic, anti-inflammatory and anti-rheumatic. But for anti-inflammatory action and anti-rheumatic action and as an analgesics, as an antipyretic, you will have to use a larger dose, higher dose. That is 650 milligram of tablet, QID, or sometimes we call more than 2 tablets because one tablet is 325 milligram of aspirin, that is we call Dispirin. It is 325 milligram. So minimum you have to give 2 tablets and you have to give frequently because the half-life is very short. So you will have to use a larger dose. Larger the dose, side effects are more. So bleeding tendency, GI side effects, damage to liver, damage to kidney becomes high. Modified compound of aminosalicylic acid, that is 5-aminosalicylates, is very commonly utilized for inflammatory bowel disease like ulcerative colitis and Crohn's disease. Based and primary drug. As an antiplatelet drug, the dose required is very low, 60 to 150 milligram. Only in case of acute MI, acute coronary syndrome, stroke, hypertension, hypertension with thromboembolic phenomena, peripheral arterial disease, TIA, you might have to give 600 milligram stat followed by a lower dose, that is 150 milligram BID or 75 milligram BID. And it is a very good drug for closure of ductus arteriosus in the person with patent ductus arteriosus. So this is regarding aspirin. It is available in oral form, ointment form and local form. Depending upon the etiology you can utilize. So salicylates are very commonly utilized but has to be used in a little larger dose in a rheumatoid arthritis, juvenile arthritis, osteoarthritis and other inflammatory disorders. I have already told you 5-aminosalicylic acid, that is mesalamine or sulfasalazine, is utilized very commonly in Crohn's disease and in case of ulcerative colitis. It is utilized as a topical preparation in plantar warts, fungal infection and also in case of a Crohn's. And aspirin is utilized as an antithrombotic activity, particularly in a person with atherosclerosis. And also it is utilized, aspirin is utilized for patent ductus arteriosus closure. So all these common indications to delay labor, patent ductus arteriosus, as analgesic, antipyretic, anti-rheumatic, rheumatoid arthritis, osteoarthritis, post-MI, post-strokes, pregnancy-induced hypertension and preeclampsia, etc. are the common use. And you can utilize depending upon the etiology, right from a small dose as a preventive measures, right till higher dose, and particularly in a person with what we call as ulcerative colitis and in case of Crohn's disease. Another compound, 5-amino salicylic acid, is commonly being utilized. In a children, very good number of time you can produce an overdose, and very rarely in an adult you get an aspirin overdose, or we call it aspirin toxicity. When you give aspirin 650 milligram, 2 tablet QID, or even more dose than that, it can produce irritability, fear, dizziness, confusion, alteration in moods, hallucination, drowsiness, altered level of consciousness. Person can develop fever, diplopia, double vision, seizures, burning pain in the throat, vomiting, decreased urination. Lot of this thing can happen. And in a children, it can produce Ray syndromes. So a child might complain of ringing, increased body temperature, hyperventilations, nausea, vomiting, lethargy, excitability. So CNS side effects, dizziness, metabolic acidosis and seizures. This metabolic acidosis and seizures produces major of the toxic problems. So depending upon that, you treat them. So first is lavage. Lavage is very important. So you can give a lavage, correction of the acid base balance by giving soda bicarb. You have to think it over. Replacement of electrolytes and full fluids. You reduce your body temperature because person develops hyperpyrexia. You alkalize the urine by giving a bicarbonates and reduce the salicylate absorption. You can induce forced diuresis by giving diuretics. You can use hemodialysis, and gastric lavage is very, very important. Now we come to the second compound we call paracetamol, mainly utilized as a antipyretic, mainly utilizes mild analgesic, not a good analgesic, but still for a common simple mild pain like headache, body ache, that is the safest analgesic. So it is called common analgesics. It is safer than NSAID, hence it is a word utilized, common analgesic. It is a safe analgesic for pediatric group also to geriatric. So that's the reason why a common word is being utilized. So because of safety, a good antipyretic effect, mild analgesic effect, can be used as any age, right from pediatric group to geriatric groups. And maximum dose, you can go up to 4 gram per day, but never go to 4 gram per day. It is said that 4 tablets of 650 milligram is maximum dose. And if you want to nullify the effects of paracetamol, you can use N-acetylcysteine. And there is a toxic metabolites, that is N-acetyl P-benzoquine amine, that is being produced, which is toxic to the liver. So if you want to reduce the paracetamol toxicity, you can use N-acetylcysteine. So acetaminophen or paracetamol. Mild to moderate pain, you can utilize that. Advantage, no cardiovascular toxicity, no respiratory toxicity. It does not produce gastric bleeding. It has got no effect on platelet. So can be easily utilized along with anticoagulation. Or it does not affect the uric acid excretion. So again it is safe. And it does not have any nephrotoxicity. It is available in oral preparation, intramuscular and IV preparations. Adverse side effects because of this toxic substance, damage to liver, and it elevates the liver enzymes. In a large dose, it can also produce nephrotoxicity and hepatotoxicity. And toxicity of paracetamol can be handled with N-acetylcysteine. So this particular can be combined with paracetamol preparations. So major contraindication only a person who is hypersensitive. You should take a precaution in a person with anemia, a chronic liver disease, CKD, chronic alcoholic, and it is a category 2 drugs during pregnancy. So it should be used with little caution during pregnancy. Otherwise, it is relatively safe. Now, if you compare the two, chlorpromazine is one of the drug which is utilized in children for reducing temperature. So NSAID and antipyretic mainly for reducing temperature irrespective of the etiology, but particularly in a person who has got hyperthermia, chlorpromazine is a better drug, but in a children, do keep it in mind, it can have an extrapyramidal side effects. While NSAID has got side effect like GI tract, but there is no addiction, while chlorpromazine can produce addiction also, and there is a extrapyramidal side effects. So while giving chlorpromazine, you have to keep in mind, and it will be a drug of choice in a children in hyperthermia. So you have to think it over. General contraindication of NSAID: ulcer, bronchial asthma, nasal polyp, diabetes, gout, influenza, Reye syndromes, person with anticoagulations, chronic allergic disorders, chronic liver disease, CKD, a person who has got a salicylate allergy, if a mother is breastfeeding during pregnancy, etc., it should be contraindicated. Gender. Also, a person who is having a peptic ulcer disease, GERD, gastritis, etc., also should not be given NSAID. In hypertension, congestive heart failure, NSAID is absolutely contraindicated. Bleeding disorders also. Now, if we compare all the three, we have given an explanation for NSAID, aspirin, paracetamol. Now, if you compare all those three, NSAID is powerful analgesic, powerful anti-inflammatory, a mild antipyretic. So can be utilized in all the three. Few NSAID may not have an antipyretic effects, while paracetamol is mild analgesic but powerful antipyretic. And I don't agree with this. Paracetamol does not have any effect as far as anti-inflammatory is concerned. But opioid is a very powerful analgesic, but no antipyretic, no anti-inflammatory effects. So it can reduce pain, but no effect on inflammation or antipyretic. Steroid is a very powerful anti-inflammatory, very powerful anti-inflammatory. Because of this anti-inflammation, maybe a mild analgesic, maybe a mild antipyretic, but should not be utilized in a person with infective etiology which produces inflammation. So opioid is non-anti-inflammatory, does not have any anti-inflammatory action, and also they do not have antipyretic effects. Aspirin will be mainly effective as antiplatelet rather than analgesic, antipyretic, and anti-inflammatory effects. So it is nowadays most commonly utilized as antiplatelet rather than anti-inflammatory, analgesic, and antipyretic. Usually that is not utilized for osteoarthritis, rheumatoid arthritis, rheumatic fever, etc. It is not commonly utilized because when it has to be used, it has to be used in a larger dose, and larger the dose, the side effects are more. Now we go to second big groups we call opioids. We have got natural opioids like morphine, codeine. We have got semi-synthetic preparations like heroin. We have got synthetic preparations like fentanyl, tramadol. Fentanyl is commonly utilized as anesthesia, and tramadol is mainly commonly utilized as powerful analgesic. So out of this, morphine, pethidine, and codeine, these are the three compounds. Here heroin very commonly, now this is very rarely utilized. The most commonly utilized is morphine, pethidine and codeine. And from this, the most common compound which is utilized is tramadol and fentanyl. So these are the common compounds which are being utilized. So we have got strong analgesics like fentanyl, morphine, etc. Moderate to low agonist. These are called strong agonist. So moderate agonist codeine, mixed agonist and partial antagonist is pentazocine, which is sometime being utilized, while a powerful antagonist which is utilized for acute intoxication by these compounds, and that is naloxone. So do remember. And we have got another analgesic we call tramadol, which is a synthetic preparations, which is having a mild effect of what we call as opioid properties, and also has got non-opioid properties also. So combining together all the compound together, you can see that all these are analgesics, but most powerful is tramadol. Opioid a little less than tramadol. Morphine, pethidine, they are less than tramadol. But codeine is a weak analgesic. Fortwin is little more than codeine but less than tramadol, less than morphine and pethidine. Fentanyl is mainly utilized as anesthetic, and naloxone is mainly utilized as an antidote for poisoning of this compound, morphine, pethidine compounds. So during that acute opioid poisoning, naloxone is utilized as an antidote. All are non-antipyretic, non-anti-inflammatory groups. They are available in the form of intramuscular IV. Mainly these are available in the form of intramuscular IV preparation. Tramadol is available as oral IV. Codeine is available in the form of oral cuff preparations, etc. While Fortwin is available mainly in intramuscular preparation. Fentanyl is available in the form of anesthetics, that is intravenous injections, and also available in the form of a patch, which are very commonly utilized for chronic pains, particularly cancerous pain and non-cancerous pain. And naloxone is available as intramuscular or IV preparation. The common side effects of all together we takes: constipation is very common, respiratory depression is very common, hypotension, sedations, retention of urine. These are the most common side effects of nearly all opioids groups. Opioids, semi-synthetic, synthetic, natural, etc. They are absolutely contraindicated in presence of shock, septic shock, sepsis, hypotension, head trauma, traumatic brain injury in a hypothyroid person, person with hypovolemia, maybe hypovolemia with hypotension, bronchial asthma, BPH because it can produce acute retention, in CKD, end-stage liver disease, in an old age person, in a newborn person, in COPD, etc. In all these conditions, by and large, it should not be utilized. It is contraindicated together. Those are available in different preparation. We have already told you: oral, patch, intramuscular, IV, or in the form of a rectal suppository also. Some are available in the form of rectal suppositories. So common side effect we already mentioned: respiratory depression, hypotension, constipation, urinary retention, sedations. A person can have a mental clouding, nausea, vomiting, headache, fatigue. Slowly person get tolerance to that, and person becomes drug dependence, addiction. Very, very common side effects. Major therapeutic uses: for diagnostic purpose, you can utilize in a dexamethasone suppression test. Sorry, this is steroids. This is for steroid. Sorry. This is for steroid. So steroid can be utilized mainly for dexamethasone suppression as a replacement therapy in Addison's, life-saving in case of an acute Addison's crisis, anaphylactic shock, SLE, pemphigus, status asthmaticus, in some of the rheumatic disease, particularly rheumatoid arthritis, some of the autoimmune renal disorders, particularly nephrotic syndromes, allergic conditions in skin, GI tract, liver, autoimmune hepatitis, autoimmune disorders of eye, and some of the malignancies. These are the use. I am not going into detail. We will be going separately when we do the chapter of steroids. So, as an anti-inflammatory in rheumatoid, osteo, ulcerative colitis, dermatosis, ocular disease, etc. And as an adjunct to the immunosuppressive therapy in multiple sclerosis, graft rejection, collagen vascular disorders, nephrotic syndromes, minimal change nephropathy, autoimmune hemolytic anemias. In all these conditions, it becomes a drug of choice. There are good number of side effects. One of the most common side effects in presence of infective pathophysiology. It can produce flare-up of infections. So absolutely contraindicated if the person has got acute bacterial, viral, fungal infections and in which you are using glucocorticoids. Unless it is a life-saving. It can flare up the underlying disease. So major contraindications. Now when it is given for a very long period in a high doses, it can suppress the hypothalamic pituitary axis, and when you suddenly withdraw, it can give rise to acute adrenal insufficiency. It will have a lot of side effects on glucocorticoid withdrawal like myalgia, arthralgia, malaise, fever, etc. It can also produce pseudotumor cerebri, very rare conditions but can produce. And on a GI tract, peptic ulcer, fatty liver, pancreatitis, nausea, vomiting. In ocular, raised intraocular pressure. Cataract it can produce. In skin, thinning, acne, hirsutism, purpura. In CNS, insomnia, depression, psychosis, nervousness, fluid retention, hypokalemia, hypertension. In general, hyperglycemia, on muscle, myopathy, osteopenia, bone fractures, etc. These are a lot of side effects, liver, cardiovascular system, reproductive system, etc. These are, and also it can produce what we can call as Cushing syndrome. So this will be all the side effects. Now apart from steroid, now you can use adjuvant analgesic, and this is the most common indication in neuropathic pain, chronic pain because of cancer, chronic pain because of non-cancerous pain, and chronic pain syndromes. In those groups, you can use this antidepressant, anticonvulsant drugs, clonidine, then GABA agonist, that is pregabalin, gabalin. DMRD is specifically utilized. This is called immunosuppression drugs, mainly utilized in rheumatoid arthritis. Some of these drugs, that is we call as the immunosuppression drugs, they are utilized in ulcerative colitis, inflammatory bowel disease, or we can call Crohn's disease. Glucocorticoid can be utilized as an adjuvant therapy in some of the indications. Skeletal muscle relaxant, local anesthetics in the form of a patch or in the form of an intrathecal, subdural, or even intraarticular. Mainly glucocorticoids, hydrocortisone can be utilized as an intraarticular injections. Topical anesthetic you can utilize. These are all included in adjuvant analgesics. Some of these analgesics are available per oral, per rectal, intravenous, intramuscular. You can utilize as a patient control analgesia. See here, patient can control on his own. As soon as the pain is less, he can cut down the drip. The pain starts, he can restart the drips. This is called patient control analgesia. So this particular instrument can be utilized and patient will control that drip sets, and that is we call as a patient control analgesia. These are also available in the form of a transdermal patch, transmucosal in the form of a jelly. Epidural, intrathecal and nerve blocks are mainly in the form of injections, and these are being managed by pain clinics and pain specialists. You have got an additional things available also. These are all local anesthetics. Local anesthetic, transdural, transdermal, transmucosal, can be local analgesic, can be other drugs also. can be other. Opioids is available as transdermal patch also. So it can be utilized in that, and transdermal patch are also of local anesthetic. So depending upon what, so local anesthetic and analgesic may be available in the form transdermal, transmucosal, peroral, perrectal, IV, intramuscular, etc. So now as far as the pain management is concerned, selection of analgesic will depend on inflammatory process, traumatic process, vascular spasm, compressions, that is neuropathic pain, or you can divide into mild, moderate, severe. Step 1, step 2, step 3 is the internationally accepted modes of treatment. Depending upon the age, newborn, child, adult, or old person, because some of the analgesics are contraindicated in old and newborn childs. Depending upon the etiology, acute myocardial infarction, colic, infections. Say in case of an infection, you don't utilize steroids. In a presence of colic, you don't require a powerful analgesic, you require an antispasmodic. In a case of acute MI, you will require an opioids. NSAID will not work. So you have to think over all this. So route will be decided whether oral, IV, intramuscular, per rectum, etc. can be decided, or a patch, etc. can be decided by severity, mild, moderate, severe, onset, acute or chronic, by etiology, age, etc. All these factors will determine. Even a cost factor should be included. So, and also you will have to look at the comorbid condition like hypertension, peptic ulcer disease, ischemic heart disease, congestive heart failure, liver conditions, liver function test, renal function, respiratory disorders like asthma, COPD, pregnancy, osteoporosis, cost, GI tract. So there are a lot of factors which will change your selection of analgesics. So you have to select a safe analgesic and effective analgesic. So safe and effective analgesics is very difficult to select. But by and large, you look at the drug pharmacology profile, patient history, diagnosis, cost, availability. These are the other factors which you should look at and then select accordingly. And no analgesic is an ideal analgesic. So you can select non-opioids, which is non-paracetamol, non-steroidal analgesics, and selective COX-2 inhibitor. While you can select an opioid analgesics, which can be a weak analgesic, weak opioid like codeine and tramadol. Opioid property wise, tramadol has got a very weak opioid property, but it is the most powerful analgesic available. Or you can use a strong opioid where you want also anxiolytic action or sedation. So basically we divide into three groups: non-opioid groups, opioid groups, and adjuvant groups. Adjuvant is mainly utilized for a neuropathic central sensitization, chronic pains like chronic pain because of certain disease or maybe because of malignancy. We call chronic cancer pain, chronic non-cancer pain, and chronic pain syndromes. In those groups, by and large, you utilize adjuvant therapy. While opioids can be utilized in different conditions. We'll be doing that particular thing now. So we have got three groups. Paracetamol mainly as a mild analgesic and antipyretic. Does not have anti-inflammatory action. You have got little stronger than that, which are very good analgesic, very good anti-inflammatory, maybe mild antipyretic. But out of this, there are some compounds which are very powerful as anti-inflammatory and analgesics. We call selective COX-2 inhibitors. And in a person with a neuropathic pain, you will use pregabalin and gabalin, which are a good analgesics for neuropathic pain. But they will not be useful for nociceptive pain. So in a nociceptive pain, if you utilize pregabalin and gabapentin, it will be of almost no use. Corticosteroids should be utilized in very few conditions. We have already discussed before. While opioids is a last choice. So it will be in a step 2 and 3. But again, you will have to divide into a different groups in a opioid. That is mild opioid groups and powerful opioid groups, depending upon the different conditions. So right time, right drug for right patient, right dose, very, very important. Right route, because when it is given by an oral route, there are some factor which decreases the absorption, etc. You have to keep it in mind. In a person with an acute, you might have to give an IV or intramuscular for right period of time. If you give it for a short period, dangerous. If you give it for a very long period, also it is dangerous. So you have to keep all those things in mind. You have to think of a pain intensity. In an acute, you will require an opioid alkaloids. Severe pain, you will require an opioid alkaloids. So depending upon that, you will select opioid or non-steroidal or paracetamol. Route you will decide according to the pain intensity, conditions. In say acute MI, by giving an oral of no use, you will have to give intramuscular or IV. You will use opioids as an analgesic in an acute myocardial infarction. While a person with an abscess, you will not use an opioid alkaloids, you will use NSAID. So you will think over that particular things. So if a person has got a mild fever with a mild pain, you will use paracetamol. So these are the points you have to keep it in mind. So they divide into 3 steps, step 1, step 2, step 3. In a mild pain, weak opioids, you can utilize, and COX-2 inhibitor you can utilize. Mainly in mild pain, sometimes you may not require a medication. It may be also even tackled by paracetamol. And then if it is not handed over, not cleared by paracetamol, you can use COX-2 inhibitor, selective COX-2 inhibitor. If a person has got moderate pain, you can utilize the weak opioids like codeine, or you can utilize fentanyl, sorry, not fentanyl, Fortwin. You can use selective COX-2 inhibitor. You can use combination of paracetamol with weak opioids property. But if a person has got a severe pain, then you will require a strong opioid, because you want to relieve the pain simultaneously and relieve anxiety also, in which morphine pethidine is the first drug of choice, and then comes what we call as a COX-2 inhibitor will be a last drug of choice. So that will be the way you will be approaching. So these are called WHO steps. First step, in a mild, aspirin, paracetamol, NSAID, and some of the adjuvant therapy to reduce your pain like local ointments, etc. In moderate pain, codeine is one of the drug. If not relieved, then tramadol, and then you can go for an adjuvant therapy. Add it on adjuvant therapy. And if a person got a very severe pain, the first drug of choice is morphine pethidine, say classical example, acute myocardial infarction. So in that, morphine pethidine is the first drug of choice. So morphine pethidine becomes the first drug of choice. And adjuvant therapy, or basically adjuvant therapy may not be useful in an acute MI, but adjuvant therapy will be very, very useful in a person with a chronic pain, particularly osteoarthritis, rheumatoid arthritis. Then in case of a chronic cancer pain, non-cancerous pain, chronic pain syndromes, etc. The fourth step has been added to improve the quality of life, and that is by adding an opioid for a long term. So these 3 steps are already present, and this is a fourth step, that is called invasive treatment in person who has got a severe pain. This is step 2, where in a moderate pain, non-opioid, that is paracetamol, NSAID, not controlled, codeine, tramadol, and along with that, you can use adjuvant therapy. If you can't use these drugs, you use the adjuvant therapy. While in step 3, when the person is having severe pain, usually this will not work. So you use the strong opioids like morphine, pethidine, and fentanyl in the form of a patch. or you can use an adjuvant therapy depending upon the disease itself. This is for a chronic non-cancerous pain. I'm not going into detail. These are the different steps, and it is associated with adjuvant therapy like transcutaneous electro nerve stimulation, or you can use percutaneous electro nerve stimulation, that is called PENS, or spinal local anesthesia, radio frequency, spinal cord stimulation. You can use morphine pump in a spinal cord, that is extradural. Surgery, you can go for a nerve surgery or you can go for an amputation, etc. All these are different modes for non-cancerous pain. These are for chronic pain, right from NSAID, opioids, antidepressant, anticonvulsants, neuroleptics, glucocorticoids, local anesthetics, alpha adrenergic agonist, and sometimes you can use a muscle relaxant like botulism toxin, Botoxin. In a neuropathic pain, mainly addition of gabapentin, etc. is very, very useful. These are some of the neuropathic pain, and some drugs are selective in some conditions. Say I have mentioned some of the conditions. In a trigeminal neuralgia, carbamazepine. In peripheral diabetic neuropathy, duloxetine. In a post-herpetic neuralgia, gabapentin and we call pregabalin. Also in case of a diabetic neuropathy, pregabalin and gabapentin is also a drug of choice. In a post-herpetic neuralgia, lidocaine patch can be utilized. In peripheral diabetic, that is pregabalin and we call as a gabapentin. In this condition, you can utilize all this. So these are all the different groups of drugs available: antidepressant, anti-epileptics, antiarrhythmics, topical applications, steroids, muscle relaxants, etc. For migraine, triptan, 5-hydroxytryptamine agonist, is a drug of choice along with mild analgesic. You can utilize mainly naproxen is very commonly being utilized, NSAID. And for prophylaxis, beta blocker, calcium channel blocker, or you can use anticonvulsants drugs. Most commonly utilized is beta blocker and calcium channel blocker. Those are most commonly utilized as pharmacotherapy as a prophylactic. In osteoarthritis, you can, depending upon the severity of the pain, you can undergo. This is right from the paracetamol till you can go for surgical treatment. These are the drugs for what we call as a rheumatoid arthritis. That is, we call DMRD. So DMRD you can utilize, you can use glucocorticoids. During pregnancy, the safest drug is paracetamol. As far as possible, no aspirin in third trimester. Ibuprofen should not be utilized in third trimester. Keep this thing in mind. It can delay the labor. Pentazocine, when you utilize, that is we call Fortwin. With caution, don't utilize this. Most commonly utilized is paracetamol, safest. These are skeletal muscle relaxant. I am not much interested in that. There are centrally acting, there are peripherally acting. Again, this peripherally acting can be depolarizing blockers, non-depolarizing blocker, that is we competitive blockers, and botulism toxin. Depending upon the condition, you can decide. So go through your at leisure times. These are all different skeletal muscle relaxants. These are spasmolytics. They relieve the spasms. Again, very useful in skeletal muscle disorders. These are centrally acting muscle relaxants. In conclusion, analgesics are definitely useful for reducing pain and improving the quality of life. But you have to always keep it in mind adverse side effects. No single drug is superior to all other. It will depend upon many factors. So depending upon all those different factors, choice of the drug will be there. Always it is an empirical choice. So I end my lecture here. I hope this will be very helpful to you, and we'll be discussing case in a subsequent lecture.